Thank you very much for inviting me. It's always a pleasure being here in Paris. Usually we have good games and fight with Regis. We speak about soccer, but today I cannot make any bad joke. However, this is a good week for Italians in Paris. So, well, you never know. Actually, I have been grown with Yannick Noah and Henri Lecomte as my best tennis player. So we will see. But we don't speak about tennis, so we will speak about aplastic anemia. And you can see here a normal bone marrow, which is full of cells. This is our own bone marrow, hopefully. And we are able to produce blood cells. But in aplastic anemia, for some reasons, we kill the stem cells. The bone marrow became empty. And as a result, we have peripheral blood cytopenia. And this is aplastic anemia, basically. We know that this is due to damage of the stem cells, which is just a matter with the amount of stem cells. We know that there is no problem with the stromal cell, it's just within the hematopoietic stem cells. There are different papers. This is a seminal paper from Judith Marsh a couple of years ago. This is another paper from NIH, from Neil Young and Jarek Maciejewski. And in addition, we know very well that these cells are normal. Basically, if you look by microarray for the signature of these cells, you may realize that they are normal. They are not like MDS cells, cancer cells. However, they have some change in the expression of genes which are related to the immune activity. And basically, this is some proof that these cells are dying, are damaged because of some immune stress. This is also true from some other paper. This was when I was at NIH a couple of years ago, able to show that we have clonal T cells, which are not malignant T cells, are just immune cells that are able to kill the hematopoiesis. And indeed, now we can go more in detail, look into for these T cell clones within different T cell compartment. This is another paper that was published recently from NIH in the Hematologica. So here we have two players. We have the stem cells, we have the immune system, and eventually the balance between these two players will give the aplastic anemia. And we have to think about a treatment for aplastic anemia. So I will support here bone marrow transplantation, even unrelated, as upfront treatment for aplastic anemia. This is the dilemma that we have: immunosuppression or transplantation. And if we go back to the EBMT data, you see this paper from Anna Lokashuli more than 10 years ago, showing that both strategies are not bad. We are able to achieve 70% survival long term with both immunosuppression and bone marrow transplantation. So these are two very good options for this patient that otherwise will be dying because of the disease. But we have to consider late events that we have in aplastic anemia. We may have cyclosporine dependence, and this applies to both immunosuppression and transplantation. Relapse, of course, mostly for immunosuppression and not for transplantation, even if secondary failure is quite common as compared to leukemia. The issue of clonal evolution, which is just for immunosuppression and not for transplantation, some solid tumors, and of course, then you have a number of complications which are associated with the transplantation, mostly graft versus host disease, but also bone disorder, metabolic disorder, cardiovascular disorder, and endocrine disorder. And of course, we have the issue of quality of life. We want to offer a better quality of life to these patients. So this is the question for today. Can we move to upfront unrelated transplantation in aplastic anemia right now? I think we have to better understand the results from bone marrow transplantation in general before making any conclusion. And you can see here that the most important factor with impact on the outcome of bone marrow transplantation is age. You see here that the results in patients younger than 20 are really excellent. The survival is higher than 80%, approaching 90%. these are two different analyses from the EBMT, whereas patients who are older than 50 have a much worse survival, around 50%. And this is because they have higher risk of graft versus host disease, higher risk of primary rejection, but also higher risk of infectious complication and other complications which are associated to transplantation. So these are the results with unrelated bone marrow transplantation. And if you go back for a second here, there is not too much difference. I didn't put the results in the same slides just because I want to stress with you that in young patients, we have very good outcome. We are again around 80%, which is not bad for a disease like aplastic anemia, but for patients older than 40, we are around 50%. So maybe we have to make some decision according to the age of the patient. But these are the results with immunosuppression. These are the data from Unrelated study using immunosuppression with or without G-CSF for aplastic anemia, and you see the excellent outcome, basically no death in patients below 20, but even immunosuppression is not so good for patients within 40 to 60 or older than 60. These are the retrospective data from the EBMT, basically confirming what I told you right now. So age impacts the outcome of aplastic anemia irrespective of the treatment that we use. And unfortunately, this is a must in medicine. The older you are, well, I don't want to say anything else because we are getting old, Regis. So, by the way, we have also some good news. If we go back to the results in the past decades, you see that we were able to improve the outcome of bone marrow transplantation. These are data from the work in the severe aplastic anemia working party of the EBMT. And this is because we were able to change some of the procedures. And here, the results are absolutely outstanding, but we will discuss in detail this data. So let's look one by one the major achievement. These are data from unrelated transplantation published by Andrea Bacigalupo a couple of years ago, showing that the addition of low-dose TBI may overcome the issue of age. You see here that patient below or above 27 here may have the same outcome if you add TBI in the conditioning regimen. But again, if you go back here, the conditioning regimen is different from the one that we use in sibling donor. This is not high-dose cyclophosphamide. This is fludarabine-based regimen with, let's say, low or mid-dose of cyclophosphamide. I would say low dose because 300 milligram per square meter is quite a low in transplantation. Let's give a look to other retrospective study showing once again the outcome. Here you have 500 patients receiving unrelated transplantation, and the most important is here. You see that there is no huge difference between sibling and unrelated donor. So if we consider matched related transplantation the standard of care in aplastic anemia, looking at this data, I don't see any reason to say different things for unrelated bone marrow transplantation, just because now we have similar outcome, but these are retrospective data. We know that there are many factors affecting the outcome. This is a paper from the French group showing that the number of risk factors may really affect the outcome of the transplantation, but nevertheless, we were able to improve the outcome of these patients. And if you look to the most recent data from the UK, data are really impressive. So here you have data comparing matched related transplantation and unrelated transplantation. you see the outcome is outstanding for both arms, but here the conditioning regimen is completely different. So you still keep cyclophosphamide and fludarabine, but as prophylaxis of GVHD, you switch from thymoglobulin to Campat. I know that this is not available in all countries. You have to use a special access. There is a compassionate program. However, look here to the results. Basically, you have survival higher than 80% in these 29 patients receiving unrelated transplantation, and the impact of age is still there. However, these are patients older than 50, and they get such a good outcome with 70% overall survival in the long term. So I think this is a very strong argument in favor of unrelated transplantation as frontline treatment for aplastic anemia. The reason for such a good outcome is that we were able to reduce the risk of GVHD. You see only 14% acute and 4% chronic GVHD. Of course, we don't want to see any GVHD in aplastic anemia because this patient have no cancer, and we have no benefit from any graft versus tumor effect. Most of these patients may have some strange CD3 chimerism, because basically they remain with partial chimerism even years after transplantation, and maybe possibly this is an explanation for some immune tolerance that we are able to induce in these patients. Going back to cyclophosphamide, this is a phase 1-2 study from Seattle showing that if you test different doses of cyclophosphamide, you may see that the best outcome is with 50 or 100 milligram per kg, which is more or less the dose that we were talking about, but is much less than the dose that we use in sibling transplantation with 200 milligrams. So basically, it's 50% of what we were used to give in standard transplantation. But we lack any prospective data. Here we have some data from the UK using unrelated transplantation as frontline treatment, but just for children. And you see here that the overall survival is absolutely outstanding. You see here that unrelated transplantation, this curve here, is basically overlapping to matched related transplantation. Of course, the difference between these two strategies, in unrelated transplantation, the previous exposure to immunosuppression may play a role, because if you treat patient upfront with transplantation, the outcome is much better than patient receiving unrelated transplantation after a failure of immunosuppression. But the most important is here, if you compare event-free survival in patient receiving upfront transplantation with patient receiving immunosuppression, there is basically no comparison. We are able to cure this young patient with bone marrow transplantation, whereas with immunosuppression, maybe we are able to have some response, but the event-free survival is quite low because most of these patients remain cyclospore independent or may relapse, requiring second-line treatment. And we know that as second-line treatment, okay, of course, this is a matter of the debate, and this is why I'm here today to fight against Regis. I'm going to lose. I know that, as usual. You are French. You are French. 3-1, even last week. So no competition. By the way, we know very well that as second-line treatment.
Those are my slides.
Yeah, no, this is Japanese slide.
This is my slides.
We got it from Shinji. I didn't know, from Seiji. So we know that event-free survival is much better as second-line treatment. So for children relapsing or failing immunosuppression, the standard of care is unrelated bone marrow transplantation. No way. And results are not so different if we use transplantation upfront. So again, there is no reason to postpone a treatment that you may require in a substantial number of patients. Well, of course, we have pros and cons, both for immunosuppression and transplantation. But just trying to list all of them, let's go back for a second to the 70s. This is the natural history of aplastic anemia. So the life expectancy was very, very low. And now we are approaching 70 or even 80%, whereas in the past, this disease was just fatal. No way. What are the other options? Immunosuppression. We know very well that immunosuppression may work in aplastic anemia. You see the survival rate, but even the response rate are approaching 70%, and we know that horse ATG should be preferred over rabbit ATG. However, if we go back to the Andretti Kelly study, you see here in this small corner the patient with complete response. They are 10% more or less, 10 to 15%. So most patients are not cured by immunosuppression. And for a young patient with long life expectancy, I'm not sure that this is the best. Then we have the issue of clonal evolution, irrespective of the treatment. We have between 10 and 50% of patients that will develop clonal evolution. And here, when I mean clonal evolution, I don't care about hemolytic PNH. I mean evolution to myelodysplastic syndrome or leukemia, so cancers. We have the issue of somatic mutation in aplastic anemia. I think we can spend years discussing the role of somatic mutation in the context of bone marrow failure, because maybe it's not like in MDS that if you get a mutation you have a cancer. I don't think so. We have just discussed this with Lucio Luzzatto in this review that will appear soon in the British Journal of Hematology, just saying that we have clones. And the fact that we have clones is not necessarily related to the fact that we will get cancer. Paradoxically, some of these clones may even cure or prevent aplastic anemia. Think to the PNH clone. We have a PNH clone. Basically, we get hemolysis, we get thrombosis, but we don't get aplastic anemia anymore because we are able to produce blood cells with a PNH phenotype. And finally, last but not least, here we have the data with a new player, Eltrombopag, that once added to immunosuppression may lead to these outstanding results, because you may have an overall response rate up to 90%. And if you look for, let's look here. If you look for complete response, the rate of complete response is no more 10%, but is approaching 40%. This is exactly what Regis wants to prove in the ongoing EBMT study, comparing standard immunosuppression with immunosuppression plus Revolade. And I think we can change a little bit our goal in the field of aplastic anemia, because I think we have now a room to look for a cure in aplastic anemia. Immunosuppression and Revolade. Not so bad. Overall survival is higher than 90% at 2 years. Not the same survival that we had in the 70s. And again, bone marrow transplantation with Campath is approaching 90%. So I think we are really changing the treatment paradigm for aplastic anemia. Let's go back to this slide. I think this is a matter of discussion later on. Immunosuppression, pros, of course, we have very low treatment-related morbidity and mortality. Treatment is ready, quality of life not so bad, and we still have bone marrow transplantation as a second-line treatment if needed. And maybe, I would say more than maybe, these results will be improved by the addition of Eltrombopag on top of immunosuppression. On the other hand, we know that we need time to get the response, the hematological recovery. We keep the risk of clonal evolution, relapse, and eventually the rate of cure is not so high. In bone marrow transplantation, on the other hand, the rate of cure is very high, but we have a risk of treatment-related mortality and morbidity. Of course, GVHD, the impact of quality of life, and if we discuss unrelated transplantation, we should never forget that to plan to schedule an unrelated transplantation, we need time because we need to find a donor and we need to arrange everything in the unit to proceed to transplantation. So maybe this is a caveat that we have to consider because before moving to unrelated transplantation upfront. And so, I mean, this is my final slide. I think the issue is not to transplant or not to transplant, but to cure or not to cure. And I'm looking for the future goals. And I think we have to consider event-free survival rather than overall survival. Of course, we don't want GVHD, we don't want clonal evolution, we don't want cancers. And I'm sure that Regis has some answer to this, because we both believe that we need prospective trials, randomized trials, and we have to generate the evidence for the best treatment in this century for aplastic anemia. And with this, I will just to thank a couple of people that are doing all this work with us. This guy here will speak in a second, and then we have a list of friends in Europe and even outside Europe, and thank you for your attention.
I would say that I met Antonio 15 years ago when I was in postdoc at NIH, and we never stopped speaking together about science, and then I think built a strong friendship and of course studies, and I think that I'm really lucky to have someone like you at the field at the international level, because it's not easy, as you know, to build some studies, to try to answer to some questions. There is a lot of competition, and I think that really it's because of friendship like this that we're doing such a good job. So anyway, now I have to destroy you. Let's come back to reality. So basically my task is to say that we should not offer to patients with aplastic anemia upfront unrelated transplantation. So I'm not going to speak about sibling, because I think that the slides were quite clear. If we have a sibling donor and aplastic anemia, then we go for upfront transplantation. This is, of course, out of questions. Everybody agrees on this. We're speaking about unrelated donor, and to give unrelated donor before any other treatment. So first of all, looking for my disclosures, you can see that there is companies, of course, but on both sides, immunosuppression and transplantation, so it's not going to influence my decision. And the thing that I find the most important is, as a disclosure, is I'm a transplanter. I'm doing about, with friends and colleagues, 130 transplants per year in St. Louis. So if I'm saying that we should not go to transplant, I would say that, or I want to stay without job, or I'm completely mad, but anyway. So that's the argument that I'm going to develop. I will be short. But what is funny, although, and I find this very instructive, as in the educational level, is that we're using the same slides, the same studies, and I'm going to present them in the other way around. That's what I really find it quite funny. So first of all, speaking about immunosuppression, well, basically, Antonio showed you these slides, and we, at the moment, are expecting in patients with aplastic anemia about 60 to 70% response, and basically 30% refractory at 6 months. And as Antonio showed you, there is this New England paper that just came out this year that's showing that if you're adding Eltrombopag, basically the response rate is outstandingly higher. And it's very easy to see here. If you look to the narrow, you see that if you are adding Eltrombopag first line, we're about 92% response with about 44 complete response. And we are speaking about 3 months. And then if we look at 6 months, 95% overall survival response. So of course overall survival is even higher. And 60% complete response. So first of all, why should I give unrelated upfront transplantation with such results? The next thing is that, of course, you quote that study. You just forgot to say that I have a copy I here.
But I can see that the name of the protocol is race, is not love, as Julien. So there's fighting between you.
It's Regis, Antonio, Carlo, and EMT, right?
Yeah, that's what we found out 2 weeks ago. Race is this. But anyway, so of course we need a phase 3 trial, and that's what is ongoing at the moment at the BMT level. And I'm very happy to present this because as you can see here, you cannot see, but anyway, there's about 150 patients already included. So we should be able to finish that study before the end of the year, of the latest early 2019. That will be the basis, we hope, for the new standard of care in aplastic anemia, meaning the association of Eltrombopag, ORS, ATG, and cyclosporine. So I hope that working on that trial together, you're not thinking that at the end it will be transplantation that will win, right? Anyway, so the next bullet is the fact that, and it's something that cannot be discussed, is that in aplastic anemia since 40 years, the most important prognostic factors is response rates. So if you have 95% of our response, this is just outstanding. And the long-term follow-up of those patients will be, of course, perfect. More or less. Anyway, so I told you more than 90% of the patients in the Eltrombopag era. Children are better responders. So it means that for patients below 20 years of age, you may think transplantations is giving less mortality, we have better results and so on, but I mean, children are responding better, so it's just a population that is going to even respond better to immunosuppression. So again, why should I go to transplantation first? Of course, if you have better response, you have better long-term overall survival, and what we do know is that if the patient is in response, then the complications long-term are lower. And basically, patients who are exposed to myelodysplastic syndrome or acute myeloid leukemia are mainly patients who are refractory to immunosuppression. So then there is this that you showed already, is the excellent results of matched unrelated donor in refractory patients. Basically, this is a study you showed, and then I'm going to turn in another way. You see that those patients have an excellent overall survival, and then the event-free survival using transplantation is far higher than immunosuppression. It was only refractory patients. So tell me why I should go to transplantation upfront when you see that the results of transplantation for refractory patients is outstanding. So why should I risk something for the patients? Because we all know that transplantation is not perfect. There is always some lottery, as we say, and I know that what I'm speaking about. That a young patient with a perfect donor is going to steroids, refractory graft-versus-host disease, and eventually dying. So why I should give to these patients first-line transplantation, since immunosuppression, if refractory, transplantation will give better results. And we know that, of course, in the case of immunosuppression, after one immunosuppression, then we have a lot of problems. So basically, if the patient is refractory to immunosuppression, of course I would not go to another treatment, but I will go to transplant without any problems because the results are outstanding, even if the patients receive immunosuppression first. Then the other thing is the data you showed on patients who have been transplanted up front already. And I would say that you say it was a nice study. I would say it was a weak study, even if I'm signing it. First of all, as you can see, it was only 29 patients. Basically, those patients were treated with alentizumab, that we know that we are not all access to. So it means that we don't know if using another drugs you will have the same results. Of course, there will be pediatric patients, even the median age was less than 10. So it's not really the matched unrelated transplantation for all patients. And finally, of course, we see that the overall survival and the event-free survival seems good. But the problem is after transplant, the quality of life, the osteonecrosis that we don't have, the long-term cardiovascular complications, and so on. So I would say, of course, this is interesting, but it's retrospective. There is no prospective trial going on, and it's only 29 patients treated only in UK and treated only with Campass. So I think that we should be very cautious regarding this. Finally, there is some technical problems that you are facing on the daily care of those patients. Of course, publishing papers is very easy. I mean, you put things together, you have far from the unit, the patients are all okay in the paper, it was perfect, you have everything in hands, you know how to say. But the thing is that in a real life, you want to offer a match unrelated donor. What do you do if the patients have no donor? I mean, we have ethnic minorities. You go to Aplo up front. And then there is another problem, is that if the donor is not available at the last minute. And I think this is the most risky situation, is that you are going to unrelated transplantation to identify the donor and to make him come in at home. I mean, to do the transplant, you need 2 months. So it means that during 2 months, the patients with severe aplastic anemia neutrophils are 200, fever ongoing, risk for fungal infections and so on. For 2 months, the patient is going to wait for the transplant. And if at the last minute, let's say 1 month and a half, the patients finally don't have a donor, we have all this experience in hands. We have all this experience of a donor was identified, everything was running well, the patient is entering in a unit, and then the donor is cancelled. So how we do? Then we begin immunosuppression 2 months after? I think this is not reasonable. The other thing, of course, is the access to Campass. At the moment, is very difficult. We are lucky in France. I should not say that, but we have access to Campass in this particular situation, in Italy too. But it's not the case for all European patients. And the other thing is the story of graft-versus-host disease. You will never, let's say, convince an unrelated donor to give bone marrow compared to peripheral blood, to give peripheral blood compared to bone marrow in this situation of unrelated donors. So of course you're going to have to increase graft-versus-host disease, quality of life is going to be bad and so on, and say there is many things that you can add to this, like technical problems that make unrelated transplantation upfront very difficult to do in a daily care. So this is what I would like to say that I think at the moment it's just not reasonable to use upfront unrelated transplant in this situation. I would just come to the definition we have from the NCI and from the National Comprehensive Cancer Network guidelines. And as you can see here, generally used to describe the most commonly recommended treatment options. So I think that unrelated upfront transplantation is not the case. And standard therapy is treatment that is accepted by medical experts, so at least we don't agree. So as a proper treatment for a certain type of disease, and that is widely used. That is not the case because we cannot use everywhere. Also called best practice, standard medical care, and standard of care. So I think that, again, upfront unrelated stem cell transplantation is not responding to this criteria. So my answer is definitely no. I would say that it's far safer, of course, to search for a MUD at the very beginning and at diagnosis. Then you begin immunosuppression, and as I show you, the prognosis of those patients who will be transplanted 3 months after because of refractory status will be exactly the same. The overall survival is the same, so there is no reason not to wait for immunosuppression response, and then if the patient is refractory, go to unrelated immunosuppression. So, of course, I'd like to thank all my friends in Saint Louis who are working on that topic, and I was not elegant enough to put your names that I should do, and I apologize for this. And again, thank you very much for your presence, and happy to take questions.